welcome to tonight's webinar. I have some really good news for everyone on this call tonight. The good news is that when you were a kid and your mama told you that you were special, she was absolutely correct, and I can prove it. If you're new to this space, my name is Justin Harris, and I'm a certified functional genomics practitioner with the DNA company. And I got to say, every day I work with people that are healthy individuals, and they're following that standard advice that they get from social media or they get from the government or whatever it is. And they still come to me with all manner of health issues, even though they're following what seems to make sense on paper. So why is that? I mean, why would you follow good quality health advice and still have a suboptimal result? I believe that the answer lies in something called biochemical individuality, right? It has to do with you and who you are and how maybe certain epigenetic inputs might enter that epigenome and end up with a different result for you than it would for somebody else. I always like to say, if I have patient A and I put them on protocol X, patient A might have a great result on protocol X. Patient B might have no result at all on protocol X, and patient C might actually be harmed and have a suboptimal result from protocol X. So we use the genes as a way of sort of navigating this entire spectrum of choices that everybody has, this option paralysis that we're all kind of plagued with today. And it shows you that you are, in fact, a special and unique snowflake, and there is no one who is, in fact, perfectly average. So we are going to dive into that tonight and talk about the genes and the different things that make you you and make Joe Blow down the street Joe Blow down the street. To discuss this with me tonight is the great and powerful Chief Science Officer of the DNA company, Dr. Krista Kusterman. Welcome.
Oh, mon Dieu. I was delighted and enjoyed that introduction. Hello, good sir. How are you?
I'm good. I'm a very unique individual myself, as I know you are. And I think we've both likely been through the ringer when it comes to trying different diets and different exercise programs, different supplements, things that were supposed to be the latest and the
Yeah.
greatest, and just had it not work for us. I mean, I know that I've
Yeah.
experienced that. How about you?
Absolutely. Absolutely. And I think part of my own experience of being told, well, if you're average, you should be doing this or you'll respond in this way. Part of my awareness that rarely was that ever the case that I responded in the expected or the average way that drove me or inspired me into the medicine that I'm now in, right? In the sense of very individualized and very personalized medicine, both in terms of an individualized understanding of body, but then I'd argue more importantly, that individualized understanding of so what? What are we going to do about that? How do we, to your point, match patient A with all of the different protocols that theoretically could be offered to them? And so I'm excited this evening to have that conversation with you. And anytime that we get to say Mama was right and you are a precious little snowflake just brings joy to my heart.
Yeah, absolutely. And it's funny, like this is why I call what we do the alignment process. I think that's probably
Mm.
in my top 10 favorite words in the English language is alignment. I call this whole
Mm.
thing alignment with your assignment, because we have this genetic blueprint that we have to adhere to. And the generic health advice that's out there might be totally out of alignment with what makes sense for your biology. So you're
Yeah.
out of alignment, even though it's healthy
Mm-hmm.
food that you're eating and a good exercise program and a good, top of the line supplement, it's just not going to interact with your biology the way that you want it to because your
Yeah.
biology is so different, right? Different
Yeah.
enzyme function, endocrine function, different. I mean, people have
Mm-hmm.
different shapes to their stomachs, and there's a lot going on. And then we add experiences and just epigenetic input
Mm-hmm.
from the time you were a kid. We all
Yeah.
end up with different phenotypes as well. So we're only in
Yeah.
control of that input.
Yeah. And so, audience, allow or enable Justin and I to kind of hang out with you for a little bit. And we're going to talk about different ways that you might be called average by either kind of like a health agency, maybe even by your own doctor. And we're going to talk about what goes into average and why you're probably special from that average. So, audience, before we begin, I want to know how many people who are here think they're average, think that based on all the regulations and all the suggestions that are out there, they fit within those. Audience, go into your chat. That's where we talk to you and just shoot it out. Say, are you average or are you a snowflake? I know snowflake's a charged word, but dance with us here. We're using it.
You
Yeah.
can call
So
it a fingerprint if you want. That's also unique to you, and it
there
doesn't have
we
that cultural
go.
connotation like snowflake does.
All right. Well, Marianne's owning her snowflake status, as are a few other people in the chat. Now, audience, here's arguably, well, maybe not arguably a more important question, but a very important question as well. Your primary care provider or a doctor who's offering you a lot of care and support, do you think that they think that you're average? Do they treat you average or do they treat you like the special little snowflake or fingerprint that you actually are? Audience, where are you on that? Yeah, yeah. I'm seeing some people toss in the chat that their primary healthcare provider kind of does treat them like the average. Yeah, yeah, yeah. Unfortunately, that's not expected, or that's expected. And hopefully, what you'll get by the end of this is really awareness as to how you do deviate from that average, and then what you can do about that, how you can actually shift your health to support that. Right? Good, Justin?
Yeah, I mean, this is the thing about like medicine and precision medicine really are different things because of that. You know
Mm.
what I mean? I mean, I think we've all been in those shoes where you go to your doctor, you have all of 10 minutes, they take your blood pressure and your heart rate, and
Yeah.
you know, they put the thing on your tongue and you cough, and it's really just this normal kind of assessment that really doesn't have a lot to do with you and all of the complexities of your biology.
Mm-hmm.
Your gut biome is going to be different than mine. Your genes are going to be different than mine. Your life experience is going to be different than
Mm-hmm.
mine. It's funny. I was just a couple hours ago, I was on a call with a patient.
Mm-hmm.
She was just telling me about being on a ketogenic diet made her blood numbers all out of whack, like
Yep.
CRP and all these different HbA1c. And then we talked about it because she has way better starch processing genetics than she does ketogenic kind of fat processing genetics. And I've
Oh.
worked with this lady for a long time.
Yeah.
We've done actually more than
Yeah.
one
Yeah.
full
Yeah.
together. And on more of a like starch base, I actually recommended something called the vertical diet, which is got a lot more starches in it. But anyway,
Mm.
her all of her numbers have improved, her energy's up, and all these different things. And it's like if you just focus on a certain niche of biohacking
Yep.
propagandist content, they're going to say that starches are the devil, right? But it's like no. For someone's biology who works really well with starches, that's going to help you with all of your metabolic
Yeah.
process. So
Yeah.
that's exactly what we're talking about. It's a prime example.
Yeah. And why don't we start with that? Because I think in my mind, at least just when we were discussing this, there's kind of five different towers categories that we want to break down this myth of average, right? We want to talk about biological variability. So that talks about your genes, how you're going to be responding to different drugs, to different food. Want to talk about normal or average on lab work and why average on lab work is probably not where you want to be. We want to talk about different age groups, how as you age, different averages are going to change and how you might be special in that way. Definitely going to be talking through calories and exercise goals because a calorie to me is very different than a calorie to Justin, even though it's the same unit. And then lastly, we want to talk through very important social determinants of health, how your history plays into your expression of genes and to even what conditions you might be prone to getting. Yeah.
Yeah, and I think another cool point here is that I think everyone, at least most people, want to live sort of an above average existence. Like that's a
Yeah.
goal that we all have to strive for. When you really sit down and you
Yeah.
picture what your optimal life looks like, very few of us are sitting around thinking about average stuff.
Yeah.
So if you want to be above average and you have, let's say, you don't have above average genetics, well, we need to
Mm-hmm.
leverage the fact that you need above average epigenetic input, right? Like
Mm-hmm.
if we can kind of facilitate such that you have an above average mindset, above average problem solving skills, or above average stress threshold, that's what's going to lend itself to you ultimately living an above average existence. And that's what we
Mm-hmm.
have control over in the first place.
Mm-hmm.
Well, I don't even want to aim for average anymore. Like, can we win? Like, let's do a
Yeah.
little more winning, right? And we have control
Yeah.
over a lot of stuff, even if your genes aren't working for you in some of these categories we're going to discuss tonight.
Yeah. Yeah. Do we have a category we want to start with? Do we want to maybe start with, do you want to start with labs or biological variability? Your
They're kind of
preference?
one and the same in a way, aren't they? I think that,
Well, let's dive into it then. Yeah.
yeah, I have something to say about labs because,
Mm-hmm.
we know that the goalpost has been pulled back to a certain extent, right? And it's like this term, the new normal, right? It's like things have kind of shifted, and a lot of different metrics that people are looking at are different than they used to be. But also, the actual like bell curve and the spectrum that we're looking at with a lot of these labs is really, really broad. And the
Yeah.
reason why is because they're getting it from this average kind of population data. Cortisol is
Yeah.
a fantastic example of that because if you get your cortisol measured and you get
Mm-hmm.
kind of the standard lab ranges, you're looking at a really, really broad spectrum there. Where if I look at someone's cortisol levels, I'm going to say, hey, dude, you're low or you're high, but you're still going to be within the standard lab reference range. So it's not meant to really look at the ideal range or like a really healthy population that it's trying to reflect. They're getting
Yeah.
those numbers from the monk who's meditating under a waterfall and looking at their cortisol numbers. And then it's also looking at people who have chronic diseases and it's looking at
Yeah.
their cortisol numbers as well. And everything within that is considered an average range. And to me, that's not a good metric to aim at, right? That's not reflective of high quality health, in my view, as a practitioner.
Yeah. And I wish what you just said was isolated just to cortisol or relatively novel testing. But I would offer that this extends into very basic blood work, right? Cortisol is something that if you go to your GP, they may not run, but your GP probably would test for thyroid, probably would test for cholesterol markers, probably would test for, several markers, which were also all generated off of what are the average ranges that we're seeing from the population. And so let's assume that that's the healthy space, but we don't know if that population was healthy. So two examples that come to my mind. First of all, thyroid, right? So thyroid is a gland that really educates and informs your metabolism, your energy, amongst a few other things. And many people will, one of the primary complaints that they'll come to the doctor with is, I feel tired. One of the first things they'll run is thyroid. And it's a really big normal range. It dips down. Arguably, the low part is probably where you want to be sitting. And then it goes up to high numbers that if I saw those lab numbers on a patient, I'd be very concerned, but those still fall within the normal reference ranges. And this is an example of, because the averages were drawn out of an unwell population or included members of the unwell population, they extend into the periphery of those being ill. So if you don't have a Justin of the world, for example, to help interpret that, your average, your RAIN or your number for thyroid might come back, and you might fall within the normal range, and yet here you are not feeling well, and you're being told you're fine because you fall within that average, right?
I can't stand that it's in your head thing too. Like some people, because of the labs, like the number on the paper is within
Mm-hmm.
that range, which we know is not a good range to be looking at. I've heard plenty of horror stories of
Yeah.
people being told effectively your symptoms are in your head. And it's like, how can they be in your head? You're your best authority. You know yourself
Yeah.
best. If you aren't feeling right, it's correct. You are correct in that. And it makes me nuts too when
Yeah.
practitioners never ask why. Like if let's say the thyroid numbers are way high or way low, they'll
Mm-hmm.
just kind of titrate dosage of a T4, T3 combo or something like that. And
Mm-hmm.
it's like there's a lot more investigative work that should probably be done thereafter. And that
Yeah.
investigative work needs to be done with this theme of you are a very unique snowflake fingerprint,
Yeah.
right?
Yeah.
Because we can look at, let's say, your liver function, your gut function, some of these things that are indicators as to how this
Yeah.
whole thyroid process is taking place. So we can then extrapolate all kinds of other stuff. But if it's just like,
Mm-hmm.
here's the range, you're a little low, we're going to give you some T3 and you'll feel better and yippee yay. This person might have gut dysbiosis and that's what caused it. This person might have liver congestion and that's what caused it. Could be HPA axis dysfunction and that's what caused it. We can't just stop right there, right? We need to make sure that we're tailoring it to the individual who is very unique, and then looking at the entire body and the functionality of how that all works. That's what holistic medicine means.
Yeah, love it. Phase tossed into the comments. Cholesterol, that is a huge one. In particular, so much effort traditionally to keep cholesterol down, and how so many people don't feel well when their cholesterol is within that average range. So I think that's a great example, Faye. I would also offer another example, and I think this one's an interesting one. Um, Liver markers. And so I learned this from someone who studied for a long time under a surgeon. And so this surgeon had been around a really long time. This person was so excited to get mentorship from someone that had, had this really long, extensive, successful career. And so this surgeon, I believe, was trained in either the 60s or the 70s. And they were very acclimated to looking over a person's blood work before they would come in for surgery. And remember, especially in the American healthcare model, surgical successes are really important because it's to an extent a business card. And so surgeons become really picky as to who they will welcome onto their table. They want to know that the person coming onto their table is someone that they can help. So, blood work, looking at blood work and ensuring the person is healthy is really important to them. So, what the surgeon would do is he would look at different liver markers to make sure, hey, can the body metabolize some of this drugs? Can the body manage this surgery? They used it as one surrogate marker for how are they going to do. And what the surgeon taught my friend was that when he started practicing back in the 60s or 70s, whenever this was, or when he was educated, apologies, um, liver markers, the range there for the ones that he would look at were a relatively low window, 5 to 10, I think was the window at the time, and low and narrow, small window. And what he noticed over the decades of his practice, this window would keep increasing. At one point, it was 5 to 10, and then it moved 5 to 12, and then it moved 5 to 15, and then 5 to 20. But as the practice progressed, there was more and more people allowed into that average space or that healthy space. And his comment was that wasn't because we were learning through medical literature that, oops, we were wrong and these ranges should be really big. It was that the average of the population was expanding in parallel to, remember, this fellow was trained in the 60s and 70s. This is in parallel to this increase of fatty liver disease, amongst many other things, amongst more poor diet, etc. And so the average person wasn't as well. And this range started to increase to reflect that lack of wellness. And so when he still examines people for his table, he sticks to his old range because he has that awareness of what was considered healthy back in the day compared to what's happened since then. Yeah.
That's so crazy. Yeah, like the
Isn't it?
actual standards we're being held to is in fact changing decade by decade. And hopefully we can start moving those numbers in the other direction with the diagnostic tools and things that we have, a more tailored approach. And
Mm.
I think functional genomics is in fact that. Like it's as close to the definition of precision healthcare as you can get. And you're not really going to know what your genomic makeup looks like without actually doing a test. It's the only way that you can really get the proper data, and it really guides all of our different things that we do at the DNA company. So it's like let's work with a more narrow range, but then let's also make sure that we're incorporating all the things that we know about what makes you an individual, because the treatment is totally different as well once you're privy to that knowledge.
Yeah. Yeah. Amazing point. I think it's not only the testing, but interpretation with folk like yourself, Justin, who live and breathe the literature and the practice of how did this average get before me? And does this person actually fit into the average? Yeah.
Yeah.
All right. I want to have a conversation next around diet and exercise because I think there's so much advice there and there's so much average there. But before that, I wonder, Vanny, Katie, if one of you could pop up the poll quiz. Thank you. So, audience, are here to support you, to offer information that you're looking for, and we do that by checking with polls. So the first question we asked this evening is, did you know that health guidelines, so this could be coming out from American institutions, any institution, is based on population averages and not individuals? Wonderfully, thankfully, 75% of our audience is saying yes, and they think it's outdated. Which, Justin, do you think it is outdated?
Yeah, I do, Dr. K. Do you think it's outdated?
Absolutely. I don't even know if it was ever dated, to be honest, but we'll let
Yeah.
another discussion. And then 10% of our audience, I like this. They're saying I've heard of it, but never really thought about it. So, audience, we're grateful that you're starting to kind of have some of these thoughts with us. The next question that we asked is, how often do you question whether public health advice, so for example, BMI ranges, calorie needs, exercise goals, apply to you? Um, and 67% of the audience, I'm grateful for this. You're a snowflake, just like Justin and I. You're saying all the time, my body does not fit that typical mold. 30% of the audience is saying occasionally, depends on the advice. And then 4% is saying rarely they trust the recommendation, which hopefully we give you a little bit of fodder about this evening. The next question here is, what do you think about the idea that normal ranges, so for example, blood pressure, are based on statistical averages and not optimal ranges? We're so close to all those words. 85% of the audience is saying this does concern them. And then another 11%, again, so similar from before, is saying I hadn't considered it before. We next asked, when making health decisions, what influences you most? 75% of this audience is saying their own body. So this means DNA, labs, symptoms, and tracking.
Good on you.
Yeah. Yeah, that's wonderful. And I like that we're entering this era of personalization and that there's empowered patients and clients that are saying, I'm doing this in that. I'd like that you're becoming more and more active participants. We asked our audience, if you found out that the average recommendations weren't working for you, what would you do? And then 70% of the audience is really change ready. Justin, they're saying they change everything they want to optimize. 30% of the audience is saying they're still in that investigation stage. And then 4%, an honest 4%, is saying stay cautious. You prefer the tried and tested, which is fair enough. We also asked you, audience, if you'd like to be personally guided through your DNA results by one of our practitioners. 26% did say that they're ready for that guidance. And so if that is you amongst that 26% or the maybes, we had about 45% maybes, please toss your information into the chat. Only we can see it, meaning the audience cannot see it. And we'll make sure that we support you in those next steps of understanding. Yeah. All right, Justin, the guru on all things that is fitness and food. Why don't we talk about the myth of average there? Because it is big and it is strong and it is ferocious.
Absolutely, and it is quite the rabbit hole. There's decades and decades going into that one, and even like you think about the Canada Food Guide, for example. We talked about cholesterol numbers and different things, and it's like the Canadian Food Guide. I believe in the United States, it's the pyramid. I think you guys use a pyramid, and we use the food guide. But either way, it's like they have taken some steps to improve it, but again, it's very much average advice. It's like kind of giving you general guidelines, and it's like I believe that the most recent iteration in Canada is like 6 to 8 servings of grains or something like that. And there may be people who that goes pretty well for, but I can tell you for sure for myself, I will definitely start accumulating body fat if I have 6 to 8 servings of grains a day. For my body, that just doesn't work. And I work out a
Mm-hmm.
lot, all these different things. And it's just because of biochemical individuality and the things that work well for my metabolism. So again, like I was talking about the ketogenic diet, for some people, that is the absolute best case scenario. I've seen magic
Mm-hmm.
happen for people on that ketogenic diet. I really have. But I've also seen people have their blood markers go out of control. I've seen people with a lot of inflammation. I've seen people gain weight on ketogenic diets. And that's because it wasn't for them, right?
Yeah.
And that's the main thing about it. Same with exercise advice. It's like some people, if you follow a guru who says that you should be running every day, and you go ahead and take that up, not knowing that maybe you have like a 5G for 9p21, and you've got really poor, mitochondrial detox, and here you are flooding your body with free radicals and wearing away the endothelium in your body, and you've just increased the likelihood of a cardiac event, unfortunately. But that other person might have had ideal genetics for that, right?
Mm-hmm.
This can have some pretty sizable consequences if you don't have some data to go off of to know this is right for my body and that's not. And with diet, it's really tricky because everything eats, right? I mean, this is an
Yeah.
epigenetic input we have to have more than once a day for most of us. And if it's wrong, it can go really wrong really quick. And I think we've both seen that, Dr. K.
Yeah. Yeah. The interesting thing about diet is you have two really important things at play, I would offer. Um, well, three. I'm going to focus on two though. The first thing, as Justin has mentioned, is your genes. So, for example, him and I both have genes that say we respond to carbohydrate in a way that may not be advantaged. In the sense of, and Justin, I'm speculating on your genes right now, but mine at least, I spike my sugars really quickly, really high when I have carbohydrate due to my genes. I also have that risk for insulin resistance because I'm not strong when it comes to leveraging my insulin for kind of management of those carbs. So the consequence to me is if I eat a normal carb diet, right, that I will gain weight and I will be unwell. There'll be an element of this not working out so well. The other two variables, which I think are interesting and really important because we're talking about don't be average and where these inputs come from, is going to be your gut biome, how your buggies, the populations, the communities of buggies in your gut will influence how you're absorbing those calories, what calories are important for you. Does your body respond better to fat? Does your body respond better to carbohydrate? Your biome will quite literally do that. And I think the third factor that I just want to pay homage to as well, because this is not addressed, especially when we're talking about average, is as a menstruating woman, or just even as a woman within medical science, our data is not always properly captured. And so, where you sit in your cycle, where you sit in your menstrual life, also has incredible impact on what diet, what exercise one should be doing. So if you just even look at those three things, there's going to be no such thing as average because those are far too complex and wide range of variables for an average to exist there, right?
Yeah, and I think that even like the carnivore diet is a pretty good example as well because,
Yeah.
of late, that's definitely been one of the bigger trends. And I've seen some pretty good
Mm-hmm.
stuff happen with it for some people as well. But, one of the things that we look at with some of the gut testing that we do is microbiome diversity, right? Like we look at alpha diversity in the gut. And if you've already got really low diversity there, which is pretty clinically correlated to suboptimal health outcomes, and then you restrict and restrict and you dial it all the way down to one food group, it's pretty likely that you're going to decrease that diversity even further, and it might actually, you may take a step forward and a step back with that protocol. But for somebody else, I've seen the carnivore diet be pretty gut healing, and there's, you're getting a lot of glutamine in that red
Mm-hmm.
meat, and it can be pretty healing if you've got mucosal barrier issues and things like that. So it's always more complicated, unfortunately, than it looks. I wish I could just jump on here and say, measure your calories, track how much you work out, and it's all done, right? But there's way more, chemistry going on there, and we have to look at all of the different factors at the same time because the carnivore diet that saved your neighbor might also harm you. So we need to be very aware.
Yeah.
That's exactly what we're talking about tonight: biochemical individuality.
Yeah. And I would offer what we are talking, especially audience. It sounds like you're either aware of or coming around to the fact that average doesn't exist, at least in terms of you. There's also the next step of now that we know average doesn't exist, what on earth do you do? If you're throwing out average, if you're throwing out this concept of average, what are next steps? And I think, you know, because I don't want you to feel abandoned out in this periphery of if average doesn't exist, what on earth do I do? Hear us when we say there's two sound approaches. Test, don't guess. So getting your biometric data, be that your genes, your gut biome, your blood work, test, don't guess, knowing your current state of affairs is really important. And then the other thing that's really important is finding a practitioner that is very focused in personalized and individualized medicine. Someone who's going to sit through all the different considerations. So, for example, with diet, we just talked about genes, biome, and gender or sex, right? Who's going to wade through all of that and understand how that is going to impact you as an individual. Yeah.
Yeah, I mean that's holistic health, right? I mean that's taking into consideration as many things as possible, and like the DNA 360 that we run, it's basically a lab. I mean you could call it a
Mm.
lab. It's a pretty damn diverse lab, but it's a lab, and I would say that labs operate as windows into
Yeah.
how the body is kind of functioning. So they've come a really long way as well. Labs, like, we can look at a lot of stuff. There's all kinds of AI and different things that are really advanced now for like looking at the gut microbiome and actually counting different things. And so look at labs in a positive light and look at them as a window into how your body is working. Oh, I have a window into my liver function. I have a window into
Mm-hmm.
my gut or my hormone function. Each and every lab is going to give you that insight. I mean, if you want to know what's going on in your body, look, that's what we can do now. So
Justin, you always have the best isms. And I would also offer, when we think through, a practitioner who's focused on the personalized and the individualized, I'd also offer, because I see this a lot in you, Justin, so I want to highlight this. I would also offer it's really important that that provider, that practitioner that you're aligning with, not only hear you, but be brave enough to hear you. And what do I mean by that? Um, I'll give an example. I have a long-standing patient. Him and I have been working together for 7 or 8 years, and he came to me when he was in his mid 70s, and his health was great, except there was this one thing that was off. And he came to me and he said, "This thing is off, and doctors have told me not to worry about it, that I'm getting old, and so it doesn't count." And I was like, "Oh, well, that's horrible." And so there's an element of being brave enough to break away from what should be happening, what the average is, especially at a certain age, to say, well, no, if you're not well, that needs to be addressed. Right. And so him and I worked together to understand what that thing was, that it was not age related. Was it age impacted? Absolutely. But it was not purely an inevitable byproduct of age. And then we worked to fix it. And we've continued to work together. And so this fellow is now in his early 80s. He looks like, and without any cosmetic surgery, he looks like someone who is in his late 60s, early 70s, and he functions like he is someone in his 40s, late 40s, but still someone in his late 40s. And I mean that across all different spectrum of being a guy. Guys, I'm sure you can understand what I'm getting at here, right? And so I would offer there's an element of bravery. And Justin, I see this in you a lot of bravery to hear the person and then be like, cool, we're going to toss out conventional wisdom. We'll be guided by it, but we're not going to assume it.
yeah, it's like I have a trick when I'm doing my health coaching. It's like I don't allow negative language. Like when they come at me with a problem, I just say there's a great opportunity for us to heal your body, right? Like I always turn it
Mm,
around on them because it's like this thing. And really, like when we're talking about human elements here, I just had someone reach out to me the other day on Instagram and ask me if I feel like practitioners are ever going to be replaced by AI. And I said, I'm not
mm,
going to get replaced by AI because people still want that connection and that person who's going to hear you out and not just look at your numbers on the paper, compare it to the average of the populace, and then just say, here you go, right? Like we want to clinically
mhm,
correlate your whole lifestyle. You lived yourself into this moment. and we're going to live you into the next moment as well, and hopefully a better moment. But that's why we're not going to get replaced. And it's because we can understand that this is a person I'm treating, right? Like
Mm-hmm.
an individual, unique snowflake of a person. I am treating them, and you'll never be able to replace having another human hear you out and then figure out and put their detective hat on and see what we can do about the health ailment that you have.
Mm-hmm. Yeah. Yeah. I love that. Now, I want to talk a little bit around kind of the other things that can make one not average that we haven't talked about yet. And so I want to talk a little bit around social determinants of health. This can be education, this can be income, this can be environment. And so I want to bring this into how AI, to your point, Justin, will never fully replace practitioners. So in our DNA 360, we look at a promoter region called 5-HTT-LPR. It's a promoter region for a gene that will help with serotonin recycling. And what it offers us really good insight into is how focused a person can be compared to kind of able to, what's the word, multitask. So focus versus multitask. It also gives us a really good sense of calm versus a little bit more on edge. Okay. And that second element in particular, that calm versus on edge, this is really even though there's an average insofar as we expect this promoter region to present in a certain way, something that influences that is going to be a person's history, especially instances of more adverse events when they're a child. When they're a child and they have certain presentations, that adverse event will influence it. And so certain presentations of this gene will come out more strongly than others. And so this is where knowing your genes incredibly important, but also knowing that don't stop at the average of genes. There's more there, and there's more that can be learned and applied, especially when you take combination, the rare combination of your genes and the rare combination of your life experience. Yeah, that will shift things.
Totally makes sense. And even like, when we're talking about neurotransmitters and things like that, like someone's gut biome from the time that they were a kid is like a perfect example. Like for example,
Mm-hmm.
I was on antibiotics for like a super long period of time as I was growing up because I had
Mm-hmm.
acne. I mean, look at me, I'm looking pretty gorgeous now, but back then it was like a problem. And again, the average advice was, well, this appears to be being caused by bacteria. So let's go ahead and put you on antibiotics. Now, I ended up on those from age 13 to age almost 18, straight. Horrible,
Oh
like,
dear.
yeah, like a really bad call. But that was just me following my doctor's advice. Now,
Mm-hmm.
I have the normal, the good actually gene when it comes to 5-HTT-LPR, that serotonin receptor site, like we were talking about. But for years following this, I was really irritable, right? Because even though the gene was good, we can extrapolate and suggest that maybe my serotonin may have been something that got disrupted
Mm-hmm.
because I was on antibiotics and wiping out all the flora for literally years, all through puberty.
Mm-hmm.
Right. So it's like that's the nature versus nurture thing. When we talk about genes, yeah, we're talking about nature and that's what it is. But what did I just say? You lived yourself into the current phenotype that you have. And now we need to add some additional and better epigenetic signaling. So you can imagine
Mm-hmm.
the work I've done on my gut since then, and actually healed myself from the inside out. But that's exactly what your point is there is that, like, yeah, we see childhood events and medications and just being on a cruddy diet or whatever it is, it lands you with this phenotype now, irregardless of what the gene was actually encoded as. Right. So we need to pair those both. That lifestyle experience, something just fell out of my pocket. I apologize. Um, and then what your genes actually look like. And it's the combo of those two that end up with the health circumstance you land with. So it's very important.
Yeah. And I would also offer to it, it's one thing to appreciate that you're not average when it comes to lab work and to kind of how you assess yourself into this is the current state of my body and this is what I need to be doing to fix it. I I would offer as well, you're probably not going to be average in terms of how do you go about creating and enacting that plan. So, Justin, let's go back to you said you have patient A and you put them on protocol X, and you have patient B and you put them on protocol X. So, technically, same protocol that can be given to these two people and will help them. Would you give them that protocol in the same way? So all the supplements would be the same, the diet change would be the same, but would you administer, teach, motivate, apply, offer that protocol to these people in the same way?
No, I wouldn't. And the reason why is because I'm privy to all kinds of information about this person. Like, for example, one of the things that I do when I get a new patient is I look at their ADRA 2B and I see how like prone to anxiety and things that they are, because I have to be aware of how I word even what the
Mm,
treatment and the protocol is to certain people, because they're just more likely to take it in a harsh manner. And I
mm,
actually have done that in my infancy as a practitioner, said something a little bit too harsh about a predisposition that they have or whatever it
mhm,
is. Right. So it's like when I have a DNA 360, I have so much ammunition to go off of about how this person is going to respond. And then it's just the actual scientific effects of it. But like, the point about the patient A protocol X thing is that like it's a good idea probably to give someone 5,000 IUs of vitamin D. Could very well be a good call. But if this person has a predisposition for calcification and really optimal vitamin D genetics, and they also live in California, and they're also a roofer living in
mhm.
California, you can overdo it on some of these protocols,
Yeah.
right? But if you live if you're in Alaska and you have terrible vitamin D genetics, then this person, that 5,000 IU, could be saving their life, like literally.
Mhm.
So that's the thing. The protocols are so different. And once we know the genetic information, we have tons to go off of. And that's the difference there. Patient A, B, and C, they're all going to respond just that little bit differently because of their biochemical individuality.
Yeah, and I would also offer in terms of their own history and relationship with health advice, right? So, for example, as a naturopath, sometimes I see people who are like, I don't like MDs for this reason. And oftentimes, like I want to make sure we're not disparaging MDs, but oftentimes it's one person didn't hear them, they had a bad experience, and there's a bit of a rough relationship there. And so they'll come to me saying, like, I never want that experience again, right? And so when you're working and offering the protocol, and I'll be plain, sometimes I'm even offering the exact same protocol that MD offered, but it's more in that delivery. It's more in the how do we understand how the person feels heard and then understands what they need to do, and importantly, are motivated to do that. And there's going to be incredible variation between people. So it's not per se that I'm reinventing the wheel or doing something that the MD did not do or was not able to do. It's more just in that delivery of how do we get the person there. And again, naturopathic practice by and large offers a bit more time than conventional MD practice. So it's not to say the MD didn't know what they were doing. It's just to say that the average experience within the medical system of what, especially if it's a GP, it's what, 7 or 8 minutes that you get before you're kind of tossed out. So it's a what's the problem? What's the average? Here's a script. Goodbye and good luck. Right. It's that idea that that human interaction, AI can't be replaced, um, gets you there. Right. You see that all the time, Justin, don't you?
Absolutely. And the other thing is like what's written on that script can be totally different. Like we have this thing called the PGX report, right? Like the
Mm,
pharmacogenomics report. And that's a direct example of what we're talking about, because like different people metabolize pharmaceuticals differently based on their genetic enzyme activity and kind of the speeds of their enzymes. So, like, if you have a really fast enzyme associated with the metabolism of a particular antidepressant, well, you're over metabolizing it. So, in order for it to work, you are going to have to titrate that dosage way, way up, which increases the likelihood of, liver toxicity and different things. And it's like for somebody else who has that medium metabolism, it probably would have worked just fine. Somebody else might have a really slow enzyme speed there, and it just doesn't work at all, right? Or more likelihood of side
Mhm.
effects, et cetera. So, like, even medications, there is a biological difference person by person by person, and different people can have drastically different effects based on the same brand and the same milligram, even if they're the same body weight, they're both females, they're both in a similar age group. Just the enzymes there is what's making that differentiating factor, let alone if it's a teenager versus a 60-year-old and one of them is 400 pounds and one of them is 100 pounds. You see what
Mhm.
I'm talking about, folks? Like, there's a
Yeah.
lot that goes into this, or should go into this.
Yeah. I think the PGX report, or that pharmacogenomics report, is probably one of, if I could teach every MD on earth something, this might be amongst that. So audience, as Justin has detailed, a PGX report really looks at, with your, based on your DNA, how is your liver or other parts of your body going to respond to certain drugs? Because when we study drugs, we're now starting to study people's genes, and we're starting to see similarities of people with this gene and therefore this enzyme respond this way to a drug. So that can inform us of a few different things. First of all, it will inform us, does the drug do what you want it to do? Meaning, if you have some pain happening in your body and I give you that pain medication, will that actually act to reduce pain? Because based on genes, sometimes it won't, right? The next thing that it can really offer insight into is the side effect profile. We know that a lot of drugs are going to come with side effects, right? One of our PharmDs, one of our pharmacists on the team likes to say it's not a side effect, it's just a known adverse event. Um, but there's an element of, some doctors will explain, hey, I'm going to give you this pill, I'm going to give you this antibiotic. Some people experience the following nausea, they experience change in bowel movements, they experience da 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 da. We don't know what you're going to experience, so here's all the things, and let me know if you experience some of the bad ones. Genes can actually give you insight into what you might be experiencing from an adverse effect perspective, which is really, really important. So when I think through drug classes where you want to get it right the first time or as close to right as you can get it, a PGX test becomes so, so important, because you go from hoping that the average of, a prescribing guidance fits you, to what do your genes say, where do you fit into that average, what should we be aware of, are there better agents for you within that same drug category? So thank you, Justin, for bringing that up, because I think that's one of our more, if I could teach all the MDs something, there's so much I would love to teach them, but that one in particular, because they are our prescribers of the world and they're very well trained in the school of medicine. Yeah, I'd want them to loop in genetics a lot more.
Yeah, just having it on hand, even about each and every patient. I mean, especially when you get patients
Mm-hmm.
that are on multiple medications,
Mm-hmm.
like, it can get really squirrely. If you're on six of them and two of them your body doesn't metabolize well at all, now you don't know which one is causing the issue. And that's a whole nother thing, right? Because the other ones that
Mm-hmm.
you are metabolizing properly, it's not that it's risk-free still. I mean, we're still taking in, milligrams of certain substances that are going to have an effect. And to your point and Dr. Stephanie's point, it's a direct effect, right? There is no side effect. It's an effect. That's what it does in the body. So, but the likelihood and the severity of it, there's a tremendous, enzymatic component to that. And we need to know what some of those enzymes look like. That's why we test the genes, because genes encode enzymes. So that's how
Mm-hmm.
that whole thing works. And if an MD was to then extrapolate and zoom out a little bit and look at your liver markers and things, understanding that, right, and your genetics as well with regard to liver detoxification, well, now we've got a really good picture for this patient, and we can minimize risk left and right. We can make it a way better circumstance. And for you and I, Dr. K, I mean, we're over here trying to optimize detox processes and methylation and get them on the right diet so that, insulin resistance is a less likely, scenario. And that's
Mm-hmm.
why our practice in real functional personalized medicine ultimately, in my opinion, gets us the best outcome, because we're taking into account all of the metrics at once.
Yeah. Yeah. I agree with that. We care a lot about what we do, and then we inform that care with data and as personalized information as science currently allows. And then we put a lot of midnight hours into reading all of the literature so that we can stay on top of it. Yeah. Yeah.
Yeah.
Yeah. All right. I want to start transitioning into questions and answers because we have a few questions. Um, Before that, though, Justin, any other pearls that you want to offer the audience? Because we've kind of, the audience, a lot of the audience came in with the awareness of, I know I'm not average. Some of the audience was waking up or recognizing this and starting to incorporate it in. For all the audience, for all our happy little snowflakes, what help them again as to now that you know you're a precious little snowflake, how empowering that can be and how you can leverage that to offer best health.
One of the first things I say to people when I have a new patient in a program is I say, I've been over 1,000 reports. I've never seen anyone optimal across the board, and I've never seen anyone suboptimal
Mm.
across the board either. Right. So it's like we've all got these strong points and these weak points. I know Kashif would call it superpowers, right? If you've got like a really, really good
Mm.
genotype working for you. And so we end up with this mixed bag, and it's like one of these things where none of these are curses. It's just an empowerment process because the devil you know is so much better than the devil you don't know. How are we going to fight the devil if we don't know what it is, who it is, what it looks like? You're better off knowing. And that's, I've said this before, but it's funny, this kind of hesitance to get your genes done because of the learning of, okay, that predisposition or this
Mm.
predisposition. But again, the mindset there is flawed because that predisposition is there in your genes, whether you're privy to it or not. And when you know it, we can be proactive and we can work forward now and we can put protocols and lifestyle interventions in place to reduce that likelihood of it ever kind of kicking off. Again,
Mhm.
we have control over your epigenetic input. And if you want to have an above average life, we need to have above average lifestyle, above average mindset, positive thought, these kinds of things. So use this as an empowerment process and learn about your body because that's going to give you the most offensive strategy. I always say we're going to play so much offense that it's going to be offensive, right? That's one of my little things because this is an offensive strategy. Once you know what we're talking about, we can get you on the right vitamins, the right diet, the right exercise program, and everything just pulls itself into alignment. It's a really beautiful thing that we do.
Agreed.
Yeah.
Go sports.
Go
Yeah.
sports.
Go sports. All right. Um, Rebecca has our first question of the evening. Is optimal basically striving to be in the middle of a uh, lab range?
It depends on the lab, right? I mean, there's certain things that you want to be a little bit on the lower end, and there's certain things that you want to be on the higher end. I mean, it kind of is dependent on what that context is, and then again, clinical correlation. Like I'll give
Mm.
an example. I mentioned cortisol earlier. If you're under a lot of stress and you've been under
Mm.
a lot of stress for a long time, and you get all this cortisol readings done, typically you do 4 a day, and you're barely making the range, and you're like, oh, my cortisol is super low. Fantastic. But it's like, how do you feel? Well, I feel like crap and I'm extremely stressed. Well, that represents HPA axis dysfunction. That's a later phase because your body's probably had high amounts of cortisol for a period of time. And then the body will start to sort of compensate and it doesn't really muster that response anymore. You're under the same amount of
Mm.
stress, but it's not giving you that pulse of cortisol, which you actually want. Cortisol's got a lot of benefits to it. There's a reason your body gives you cortisol. But you
Mhm.
look and that's the low end of the range, and someone goes, look, this is a stress hormone and you're on a low end, right? You're barely making the range. To me, a clinical correlation with that would say this is bad. We need to support that HPA axis because you should be mustering more considering what your life looks like, right? And I think thyroid's similar. I think that a lot of these kind of markers are
Mhm.
similar. You've been under so many, like over so many labs. What do you think about that?
Yeah, I um very rarely I tend to I tend not to see individual markers. Some I will, but I try to look more at the constellations. I try to look at what does the entire picture tell me. as opposed to an individual lab work itself. Um, and I think that really helps me ground against who's before me. Sex, biologic sex, tends to be really influential, how old they are, especially in regards to hormones. And so these sorts of things will really inform me as to where I want this person. Including race. I don't think that's something that we've discussed today, but race will shift how you need to be interpreting certain labs, not all labs, but certain labs. Um, and so I think it's really important just to see the person before you, see the goals they have. I think goals are another really important part of this conversation. So, for example, a female who wants to get pregnant, where they would want to be in those lab ranges is going to be very different than, for example, a female who is an athlete training for a particular event. So saying, do you want to land in the middle of something, Rebecca? Sometimes, but that's always going to be contextualized between about who you are and what you're wanting to do. Yeah.
Yeah.
Yeah. Yeah.
Treat the person, not the paper, right?
Ding, 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 ding. Yes, sir. All right. David has a question here. David is asking, how do you narrow down the supplements to focus on based on the DNA 360? So, for context, Justin, I'd love if you want to answer this one, but just audience, for context, when you get your DNA 360 and you're diving into the individual modules, um, in particular, if it says you're suboptimal in a space, it will then follow with some recommendations. Some of the recommendations are going to be lifestyle, meaning like, hey, you have an increased risk for cardiovascular. You might want to consider running. Or a recommendation might be you have an increased risk for diabetes. You might want to be mindful of your carbohydrate, for example. It's also going to come in with, hey, you have an increased risk for feeling stressed a lot of the time. You might want to consider these adaptogens, which help you reduce stress. So, Justin, especially for someone who might be suboptimal across several different towers, and there might be several different supplement recommendations, I would speculate you're probably not going to say all of them. What's your guidance as to where do you focus? What do you do?
It's really funny. So, like, supplements are absolutely an important thing, that we talk about because it can really help fill in the gaps. When we have genetic weak points, it's like sometimes some of these processes need a little boost, a little bit of a cofactor for some of these processes. But I'll tell you more and more when I have patients coming to me, they've got this huge long list of supplements, and I'm finding myself actually whittling their list down more so than adding to it. I might dial it in a little bit and add something that's really specified to what they require based on not just their genes, but how they present. Like how they come to me with, like, okay, this person is not detoxing well. Like they need some help there. But
Mm-hmm.
I'll really look at the entirety of it and I'll kind of correlate with what they're already taking, what they're eating, what their lifestyle is, and then I'll extrapolate from there. So I don't have like a set in place system because the option paralysis at this point with the supplement industry is so massive and everyone is on so many different things. I'm usually removing prior to adding. Like I'm finding
Mm-hmm.
myself doing that a little bit more. And again, this is really, really personalized because, for example, I'm a really big fan of digestive enzymes.
Mm-hmm.
I think that a lot of people benefit from them, and probably most people would. And I can look at the gut genetics, and I can look at the gut, the actual test that we do as well. And some people aren't going to do well on a lot of proteolytic enzymes because they may have something like H. pylori present. If you take a lot of protease when you have H. pylori, and I'm saying elevated H. pylori, a lot of people will have a little bit in there. It can make it so that it amplifies the downside of that, right? Like you don't want to be taking lots of protease if you are elevated for something like H. pylori. That's why this is such an individualized process, because for somebody else, like myself, I take a lot of digestive enzymes, but I do my gut mapping and I know that I don't have a lot of H. pylori in there, right?
Mm-hmm.
So I don't have a real blanket answer to this question because it's truly a clinical correlation process. I use the genes, we use the labs, I look at their lifestyle, I have everybody send me what they're currently taking as part of the intake process, and then we whittle and we tweak from there. And sometimes I add, a lot of the times I subtract.
Mm, mm, mm. And I think That's that's the power of personalized medicine in particular in regards to kind of supplements. I think universally that's probably one of the bigger things that we do, Justin, when people come into us is we take them off a lot of supplements because there's temptation to fix an ill with a pill, and that isn't always the solution.
Yeah.
Yeah. No, I think it's reasonable. It's really David, we're not trying to deny an answer here, but there's an element of there's so many things. Just even listen to what Justin said. I consider the gut. I consider different pathogen strains. I consider genes. I consider, the person's preferences. All of this will go into where do you want to focus on? And so I really encourage you to find a provider who's literate. Feel free to reach out to us. We can support that, who will be able to guide that. I think, even if you're like, I come from a pretty good state of health, just sitting down with someone and clarifying health goals that you might have and where to start getting that traction in your life, just even over a few small sessions, can be really helpful. I think I see a lot of people planning for financial future, for career future, for family future. And not as often do I ever see people come in and plan and have a health plan of where am I at right now? Where do I want to be? And so it's an opportunity, I think, especially when you get your genes to be like, cool, where am I now? And where do I want to be? And how do my genes facilitate that future vision? Yeah.
Yeah, it's vision construction, right? Like that's what we do, and like that's why like even with things like bodybuilding lifestyles or whatever it is that you do, we're always trying to construct that vision. Like that's what I was talking about earlier with regard to average being kind of below average now in different ways. It's like you need to understand that we're trying to get you to the actual life you want to live, right? So we're
Mm-hmm.
constructing that vision and we're doing it daily and we're doing it by controlling the epigenetic input. Supplements absolutely are an epigenetic input. They're going to impact your physiology. Um, so there's a lot that goes into it, like Dr. K was saying, but it's about constructing the ideal vision. And I think that there's tons of metrics that you have to look at to do it properly.
Yeah. And having a provider that's brave enough again to hear you and brave enough to see potentially if it's appropriate outside of the average. There's some hard and fast rules that you're never going to deviate from, but by and large you want a provider that can discern between the two. Where is it appropriate to be average? Where is it not appropriate to be average? And how does this fit in with your health vision, your health goals?
Yeah.
All right. Faye has our next question. Faye's asking, which genes are we looking at in terms of drug effectiveness and side effects? So, Faye, this is not something captured within our DNA 360. What you'd instead be doing is our PGX test. So close, which stands for a pharmacogenomics test. And so this is a very specific panel. It will come from another a cheek swab or a saliva sample, and it looks at your genes, but more in terms and comparison points to different drugs. Okay, and so if you want that, the powers that be are going to toss that into the chat so that you can have a link directly to it. Okay. All right. David, double header. I think that's a sports reference. Next question. So many online longevity companies are selling protocols that involve prescription drugs at low doses, um, like sirolimus, which can have side effects. Do your protocols start with supplements first? Well,
For me personally, as a practitioner, I do not have prescribing authority when it comes to pharmaceuticals. I have opinions on them, and I cannot tell you take this or do not take that. So for me, I stay within the supplement realm. But to be perfectly honest, I would probably not deviate that far from it in any scenario, just because to me, I always start with the basics and things that are more nutritive derived. Now, that being said, I don't mean to crap on pharmaceuticals. I think that there's plenty of brilliant science that's gone into a lot of them, and I know a lot of
mm-hmm,
people that take low doses of metformin or some of
mm-hmm,
these things that can have some benefits. Even, and I might get crucified by some of the community for saying this, even low dose statins, I think, can have some
mm,
benefit there while you learn how to eat. Right. And while we fix some of the other detox processes and get your insulin under control and whatever. But drugs have a place and a purpose,
Mhm.
and there's been a lot of great science that's gone into them. I try to aim for the areas that are going to really reinforce genetic weak points. And I think that drugs, even like a methylene blue, is you could consider it a drug. And I think there's plenty of
It
value in
is.
some of these things, but it's a later conversation. I think the problem with medicine is that drugs are the first, second, and third line of defense when we haven't even talked about lifestyle. I mean, how many people are on statins and a full dose of statins that just continue to eat in a way that doesn't make any sense?
Mhm.
And that's part of my problem with drugs and going to them first is that it's like it's a band-aid effect and then we're still not correcting the underlying issue. And now you've got to be on this thing forever and ever. And it's probably lowering your testosterone and causing mitochondrial toxicity and all the things that can happen with higher dose statins, especially. So yeah, I mean, I don't mean to sound like I'm not a fan at all of drugs. I think they have a place. I think doctors have a place. If you break your arm, don't come to me. Go to the emergency room, man. I don't know what to
Yeah.
do. I'll duct tape it. I'm from Canada. We just duct tape stuff. So there's a reason why you need hospitals and ER and medication, etc. Justin has his own realm, and I'm quite happy staying right in there. What do you think, Dr. K, about that?
Yeah. David, I would offer the answer is maybe. To Justin's point, and I wholly agree with it, it's not necessarily going to be where we lead with. I think that to Justin's point, we address foundation first, because if you follow any longevity expert, and I know there's several out there right now, there is not one of them that will sit there and say a low dose metformin or insert whatever repurposed drug will take the place of good diet, good sleep, good foundation. So I think Justin makes the strongest point by saying we start with foundations first. Now, once those are all in point, it then looks at what are your health goals in terms of longevity. So, for some people, for example, I know that low dose metformin is really popular. So, low dose metformin is a drug agent that supports with insulin regulation. And so it really supports blood sugar levels. And there's some, I don't know if a lot is a fair phrase, but there's a bunch of people that prescribed by their doctors, they're taking low dose metformin because we know that dysregulated blood sugar is an incredible contributor to aging. So the hypothesis is if we offer low dose metformin and we give people who don't have diabetes, who don't have, at least according to blood work, any blood sugar dysregulation, if we give them that, that will help better control their sugars, keep it more within a fine window, and add to their longevity. But as we did that, we started studying it and we saw that it also curved inflammation in a way that wasn't helpful. When you went to the gym and you worked out, it stopped some inflammation that then stopped muscle building and stopped benefits of exercise. And so, David, what I would say to the end of do we use medication? Foundation's always first. And then after that, it's a conversation. What are your health goals? And how might the agent support you? How may it not? And then allowing that conversation to go from there. Because it I would say it is grievous that companies advertise a program and bring you in and say, this is exactly what we're doing to you, with you. Here's the program without any variation based on your personalization. And it's the personalization that becomes really, really important because it is through your genetics, through your lab work, through your understanding of here's the pros of taking this low dose medication versus the cons that get you to that answer. It's not our job, Justin, nor I, nor any of the other practitioners here will ever tell you you should do this. We're going to present information and then you get to pick from there. And that's the important part. It's never going to be a program that everyone fits into. It's going to be a conversation of what do you want and then how can we support you getting what you want. Yeah. So,
Yeah.
David, I hope yeah, Justin, another
I
thought?
was just well said. I was just going to compliment you on that. And the other thing to say about that is like, usually, I mean, we're using metformin as an example, but this could be any other thing, right? Like, I'll usually find the alternative as far as like, well, I mean, have you tried intermittent fasting? Have you tried some blood glucose, some natural blood glucose disposal agents. I mean, I'm sure that there's a lot of things that we can start with. And that's where I talk about general to specific in my health coaching, right? Like we start general, we move to specific. Drugs are going to be really very much a specific protocol, right? And it's like I've always found that, the general principles of health building are always going to outweigh and outperform some of these really zoomed in treatments like drugs. That being said, I mean, hey, my daughter has epilepsy and she needs that clobazam and she needs it twice a day. And no amount of
Mm-hmm.
me health coaching her and making her do
Mm-hmm.
breath work and this and that, it's not going to stop her from having that seizure. It's not going to impact that really specific receptor site that's causing that. The clobazam will do that, right? So it's like there's a time and a place, like I say, but I really don't want to go right to that if we don't have to, because there can be other effects. It can gum up your liver, right? There's other things that it can do that are suboptimal, and we're always aiming for longevity and quality of life first.
Yeah.
So drugs are part of that totem pole, but it's a latter part, and we go towards all of those health building principles first.
Yeah. Yeah.
Yeah.
Agreed. Agreed. I think it's always amusing to me when people get surprised that I'll sometimes redirect them back to what they consider conventional medicine or big pharma. And that's again me coming from a naturopath. So I'll borrow a few stories from when I was doing my training. I worked on um, I did a focus shift that focused on adjunctive cancer care. And as some of the audience can speculate, I saw a wide range of people insofar as some would come and say, "Hey, I have cancer. Here's the treatment. What are complementary things that adjunctive things that can support me through this period?" They weren't looking to replace their conventional medicine, they were looking to complement it, right? And then there were other people that came through and said, this is big cancer. It's all fake. There's a natural cure. What is that natural cure? All right. And the conversation with them would always be, okay, let's understand the diagnosis. Let's understand the recommended treatment. Let's understand how much of a fit. Do you fit within the average, the audience, the population that this is actually going to support? And oftentimes the answer was yes. And so the advice was we'd go through that, right? It's the person's decision. It's not my decision or my telling them, oh, you should go do chemo or radiation. It's here's the information. Here is maybe you do fit within that, right? And if that's true, let's look at what we can do to mitigate side effects and to ensure you get through that. So that conversation is really important as to where do you fit within that average? And then how do we best support you fitting into those end goals? Yeah. And so medication is not the enemy. I would offer the enemy is trying to adhere to this idea of average, be that in how your labs present or standard of care. Because ever so occasionally we would see someone where that cancer, the treatment wouldn't necessarily help, but it might prolong life, and that life prolongment wouldn't be comfortable. That's a different conversation, right? It's really important to have those sorts of conversations with your provider, to trust them and to know that you're not average. And how does that live out in your engagement with your doctor? Yeah.
Beautiful. Yeah, that's like the vision construction that I was talking about earlier. Like, how do you picture those latter years of your life? Because there may be certain protocols and drugs that can, in fact, expand that. But what does it actually look like in real practice? You
Mm-hmm.
need to really make sure that even if you are going to go ahead with some of the harsher medical treatments, I think that to your point, complementing that with all of these other protocols can make it so that you end up with a better overall health outcome. Even if it is like just something simple like antibiotics, like, well, let's also complement that with some gut health strategies and counteract the downside of the pharmaceutical with some of our health building strategies. You're still better off that way.
Mm-hmm.
So this marriage between the two is ultimately where medicine is probably going to arrive at, and I think that's a step in the right direction.
Mm-hmm. Yeah. Yeah. It's to borrow from the Buddhists, it's the middle path typically that not always, but typically that runs out. It's that integrative path. Yeah. And I think the foundations of that integrative path are knowing yourself, knowing the DNA that found you, knowing the blood lab work of, various blood parts of various liver byproducts, the metabolome, right? All those fun things, knowing your current state, and then working with someone to really marry that together because you don't want an average plan, you want your plan.
Beautiful. Couldn't have said it better myself.
Yeah, yeah, yeah. I think it's medicine's in a really powerful place right now in that because of all this data, if it's properly brought together, it can at the bare minimum make your life better, but in extreme cases save lives. I think in particular to PGX testing and knowing how medication will respond within the body. I think to liquid biopsy testing, right? We've that will look into the blood and say, "Hey, there might be some cancer perking up. Let's address this now versus later." Right? It's this sort of data-driven healthcare that doesn't assume average and normal. That's really important. Yeah, we didn't even discuss kind of um, lab work, blood work that can kind of tune into, are you at risk for developing or are you developing current tense cancer? We should have.
Yeah, and also I wanted to bring up things like BMI and like RDAs as well. You know, some of these really just average metrics that we go off of that really don't have a heck of a lot of clinical correlation to someone's state
Yeah.
of health. I mean,
And we have
I'm
10 minutes,
I'm
sir. So
obese.
let's do it.
All right, let's do it. So I'm
Let's do
obese,
it.
right? When it comes to the BMI, right? Because for my height and I'm over 200 pounds, right? And it's like, again, these are the things that we talk about. This is an average measurement, but what does it really mean? Because the real reason why I'm over 200 pounds is because I've been lifting weights for 15 years, right? And I've actually got a pretty healthy, body composition, body fat percentage. But according to just the BMI and that metric, I'm not in a good place right now. I shouldn't be over 200 pounds, but I am, right? So some of these just standard things that we look at that are average, quote unquote, have no correlation to how healthy you are and how well your body is functioning.
Yeah. Those averages were derived from white men and women in the early 1900s. So unless you're a white lady or man from the early 1900s, chances are that system does not apply to you. So just as a heads up, just as a heads up, it's a very antiquated thing which prayers to the gods will one day work itself out. Do you want to? Oh, you got me on an angry tip now. All right, Justin, let's go into RDAs, and I'm going to be angry in the corner.
Yeah, so the recommended daily allowance of certain nutrients, like if you go on the back of something and it'll say vitamin C and it'll say this is 2000% of the RDA. Understand that when you actually read through that, at the bottom it'll say these metrics were obtained by, based on a 2000 calorie diet or something like that. It has to do with the macronutrient and the micronutrient relationship there that has nothing to do with, let's say, genetic metabolism of vitamin C, which we look at, a gene called SLC23A1. Or it'll talk about vitamin D and you have X percent of the RDA, but not knowing that you have a totally suboptimal receptor site, which we call VDR, vitamin D receptor. So how much are you absorbing? What's your activity level? How much of that magnesium are you actually burning through? Or how much are you losing by going to the bathroom? How much do you sweat? All the mineral RDAs are going to be totally, skewed based on what your lifestyle looks like. So based on a 2000 calorie diet is a really, really odd metric to be trying to base what that RDA actually looks like. And there are people that still try to kind of base what their supplement goals are on the RDA. And that's as bad as following the Canada Food Guide, as far as I'm concerned.
And so many of those RDAs were established in the 50s through prison studies. So again, you're looking at a population of largely men, but their diets were profoundly impoverished of nutrition based on the prison systems and what the food they were afforded at the time. So again, unless you're a man from the 1950s, there's been research that goes into it since then. I'm not painting a fair picture, but do understand some of the mentality that goes into how those sorts of things were established. Yeah. Yeah. Um, I'm seeing a comment from Nina just quickly in regards to our liquid biopsy. And so just in closing, it's just so the audience has awareness of it. Oh, okay. All right, guys. I'm just looking at the clock. I didn't realize what time it was, so I want to honor the time that we have. Justin, sir, it was, as always, a pleasure. You educate me every time we jump into this room, and I'm so very grateful for you.
Oh, ditto. And they're always so much fun, and we got to tackle a little bit of a different topic.
Mhm.
I'm so grateful for you guys as well to be here, folks. Just remember, this is an alignment process. Everything we talked about tonight, including PGX, all the different things that we tackled, it's an alignment process. If you've got a health goal in mind, you have to align your energy, thoughts, and actions with the attainment of that goal. It's the only way you're going to get there. If any of these pieces are out of alignment, you've missed one of the pillars that's going to get you there, right? Energy, thoughts, actions in alignment with the goal that you set for yourself. And so keep pressing forward and do so much offense that it's going to be offensive. Uh, Grateful for you, Dr. K. This is always so much fun.
Sports. It is, sir. All right, audience, it is time that we dance out. Thank you so very much for being here with us this evening. Justin, shall we dance?
We shall dance. Good evening,
D'accord.
everyone.
Au revoir, mes amis. Au revoir.
Bye, everybody. Thank you very much.